On today's episode of 340 Banter, we're going to talk about the newly announced or recently announced 2028 negotiated MFP drugs. Logan, can you kind of give us a little background why are we learning about drugs that are coming into effect in 2028 now? Why is this a big deal?
So, as part of the Inflation Reduction Act, we get those drugs almost 2 years ahead of time, which is actually good for us because it allows us to prepare for this and start planning as to what the impact will be. But there are specific timelines, and CMS had until February 1st, 2026, which they released it a few days ahead of time, which is good because the government closed. But they got us this list about a week ahead of time, and it indicates what drugs they'll start the negotiation process on, and that takes time. So that's why they announce it early, so they can work through that negotiation process and get the negotiated prices out by the next timeline that they have highlighted.
And I know that kind of 20 when they announced the 2027 drugs, we saw that was really going to be the year of diabetes
Yeah.
drugs. That's when all of them are getting added is next year. What trends are we seeing with the 2028 list of drugs?
I think a big thing we really haven't seen as up to this point has been that 2028 starts negotiation for Medicare Part B billing. Previously in 2026 and 2027, we've really focused on the Part D. So I think that has shown itself in the list that we're starting to see a lot more drugs that may be in the Part B space, which for a lot of health centers and other grantees, this is, I think, great news. This allows them, these will be less impactful for them, but hospital entities may be hit a little harder with these list of drugs.
Part B is the provider-based, provider-based is very specific in the hospital world. It is the physician-administered, clinic-administered drugs that are billed to Medicare, whereas the Part D is what we're seeing now. It went into effect January 1st of '26. Part D is for drug. It's the retail pharmacy drug claims.
Yeah, and that's what we see the most in a grantee. They don't have a lot of Part B billing. For example, in an FQHC, all of our billing goes under Part A and even the medical side. So, the only place you might see Part B billing in a health center would be in the pharmacy if the pharmacy's billing Part B, which is pretty rare. Does happen on occasion, depending on
You have
what
to get separate
patients.
credentialing for it and things too.
Correct, yeah, there's a whole different process to go through, so we don't see it as much, but, that's really going to affect the hospital entities more than the grantees. So, Chels, we've seen a lot of drugs, just a heads up, 2026, we had 10 drugs, we had 15 in 2027, um, 2028 is also 15, and then looking forward, we'll see 20 drugs each year after that.
And they're additive. So it's not that they replace the previous drugs, they get added onto the previous list.
Exactly, and drugs can come off the list as well. So that's a different process, that has several factors that drugs could come off. But Chelsea, let's kind of go through these drugs and see what the impact is to the different entities and what kind of trends we're seeing in the list.
Yeah, I noticed there's, a lot of oncology and
Mhm.
rheumatology drugs, which, as you pointed out, makes sense looking at the shift to inclusion of the Medicare Part B negotiations. So we have Cimzia, Cosentyx, Erleada, Kisqali, Lenvima, Orencia, Verzenio, Xeljanz, a lot of those ones that aren't necessarily your kind of run of the mill. Everybody everybody gets them. They're a little bit more unique, a little bit more specific. And again, tying closely to that Medicare Part B inclusion. that starts this year.
Yeah, and I think, where we're gonna see that the most for, I would say, majority of grantees is through a referral capture. So if this is hitting you at all, it's going to be through referrals because, you're generally most grantees don't have rheumatology in their scope. It can happen. Some health centers do have rheumatologists, but they're, pretty rare, and oncology is definitely more focused in outside practice, outside of grantee covered entities. So, keeping track of this for your referral capture is really important. And I think really looking through those, whatever service you're using for that referral capture to see if you're dispensing these drugs is going to definitely be advisable.
And I think kind of narrowing down the list to the drugs that will still be impactful for hospital entities, but are probably more relevant for grantees, um, would be your Anoro, which is for COPD, Biktarvy, which is for HIV, and then we have Trulicity for diabetes, and then maybe impactful, maybe not, Rexulti, which
Mhm.
is an antipsychotic. So I think we've got, 3 or 4 drugs that are probably more relevant to grantees than the others, whereas, the majority of this list is likely to impact those hospital covered entities.
The interesting thing, I think interesting anyway, and I'm a nerd, about Trulicity is it's one of the last holdouts in the GLP-1, category to be added to the list. We saw, the Ozempic, and some of the other,
Mounjaro hit in 2027
yeah.
or will hit in 2027, Wegovy.
Yeah, so we're some of the biggest ones are already there, but Trulicity was back a little bit. So after starting in 2028, pretty much all GLP-1s will be subject to MFP at least until they're removed from the list. The other big thing we've seen here is the Biktarvy. Can you talk about the impact there?
Of course, so Biktarvy is definitely one of the most commonly used drugs for an HIV treatment right now. And so if covered entities, are prescribing treating HIV population, this is gonna be pretty significant. And while we don't have the negotiated prices yet, I would anticipate that there would be, it's going to be pretty significant impact for pharmacies in general, to buy and replace that drug, but also for the covered entities, particularly, talking about the overlap with the 340B program, which are 340B eligible claims and which are not. Hopefully, we have a much smoother process for deduplication at that point than we do now. Um, but it could be really impactful for pharmacies to not get the refund on that down the line because it is such a common drug to treat HIV at this time.
Yeah, I've talked to some, entities that really specialize in the HIV care, and to date, they haven't been impacted significantly with the 2026 drugs, but they have been expecting for some time, and we have as well that Biktarvy would be added to the 2028 list, just looking at the spend, that Medicare's spending on that drug. So we've all been expecting it, and I think everyone's waiting for that, shoe to drop on how big of an impact that's going to be
Yeah.
financially.
So what do covered entities need to be doing now? Kind of thinking through covered entities or even pharmacies acknowledging that these prices may not just impact those that are 340B covered entities because every pharmacy is dealing with this for reimbursement, and having to go through the refund process. What do they need to be doing now looking at this list of drugs?
I think, now is a great time to be, kind of looking through reporting, seeing how often you're filling these drugs, because that's really going to impact if you're doing one or 2 Biktarvies a month, you only have a couple HIV positive patients, it may not be as big of a hit. I'm gonna guess for most of your grantees, unless they treat HIV patients, this one is kind of a, okay, it's a little bit of a pain, but not like 26 and 27. But if you have a large percentage of those patients, then it's really going to hit you further. Along the same lines, I think now is the perfect time to start evaluating the impact for 2027. We really started doing that about this time last year for the 2026 drugs. You don't want to do it too early because 340B prices change significantly, and we saw a lot of
And we don't know the negotiated prices for these ones
not for
yet.
the
We just know that
2028
these are the
drugs.
drugs that are
Yeah.
selected. Yeah, yep, so you can't do that analysis
Yeah,
yet,
you
but for
can't
the
do it for
2027
28,
drugs, you
but
can.
we got the 2027 negotiated prices in November. And that's a great segue because we'll be getting those 2028 prices this coming November, in November of 2026. So we will look at those prices once they come available. But right now, looking at volume is a good idea. But then also starting that analysis for pricing as far as your 27 impact. We did see one of the drugs for 2026 come off the list at the end of the year. So instead of the 25 drugs we were expecting, we'll only have 24 included. But really starting to do that analysis, and that kind of goes to the point that this is going to be ongoing. We're going to have to keep doing this. It's going to be a cycle we have to get used to, looking at the next list and evaluating the impact. So I think developing a process now will help you be more prepared each year when we get the next list.